Welcome to yet another weekly Pediatric Hematology Oncology training session for the fellows. We today have a very interesting topic and a very esteemed faculty to be part of this. So thank you, Dr. Sandeep, for first of all moderating and accepting to be part of the session today, and to Rajiv Gandhi Cancer Center to be taking the case and the discussions today. So before going ahead, I would like to introduce our faculty for today. We have Dr. Gauri Kapoor, who doesn't need introduction to this audience, though. She is the medical director at Rajiv Gandhi Cancer Hospital and also head of the Pediatric Oncology division there. She was our chairperson, the immediate chairperson of the Pediatric Oncology chapter. So welcome, ma'am.
Hello, everyone. Hello. I hope you enjoyed today's session.
We have Dr. Siddharth Lashkar, who is professor of radiation oncology at Tata Hospital, Mumbai, and he's also the deputy director of academics there, currently. So thank you, Dr. Lashkar. We have heard at various podia, so it'll be great to have you with us today. We have Dr. Shalini Mishra also. She is a senior consultant in pediatric oncosurgery at the Rajiv Gandhi Cancer Hospital. I've heard ma'am many times, so thank you for your time, Dr. Shalini, today. With that, Sandeep, I'll hand over the session to you. So before I do that, thank you, ECHO, for holding it again today for us, and also to our academic committee who kind of brings these programs every week. We have a group of people dedicated to do this week on, and especially Neeta and Anand, who takes a special interest in getting these sessions together. Over to you, Dr. Sandeep. And one more before you start, request for everyone is please put your videos on so that you can see each other, and please interact during the sessions. These are basically not for us; these are for the fellows and the trainees. So please get involved yourself and put your videos on. Thank you, Dr. Sandeep. Over to you.
Thank you, Sunil. I hope you can hear me. Okay. Very good evening, everyone. At the outset, I must appreciate the effort of IAP PHO group to conduct this training session for the fellows. And I think in last few weeks, we have covered many useful topics. And the topic that has been assigned to do today is on rhabdomyosarcoma. So we shall be covering it in two parts. First, there will be a case presentation by our fellow, Ayushi, and then we will have two small didactic lectures. So, as we know that the rhabdomyosarcoma management is multidisciplinary, so we have actually three experts from three different domains. One is like surgical oncologist, one radiation oncologist, and one pediatric oncologist. So we shall try to cover the basics of rhabdomyosarcoma, which will be useful for the fellows. And with that background, if my experts permit me, shall we start the case discussion?
Yeah, sure.
Okay, so I'm handing it over to Ayushi, who will be presenting the case. Over to you, Ayushi.
A very good evening. So today we will be discussing a case of a 2-year-old female who was born of non-consanguineous marriage, first in birth order, who came to us with the complaints of passage of fleshy material and clots in urine for 2 months, polypoidal mass from vagina for past 15 days. There was no history of trauma, bleeding, fever, or weight loss. There was no family history of cancer. Her birth and developmental history was unremarkable. She was investigated elsewhere, which included only a USG, which showed a polypoidal mass arising from the vagina. She was referred to our center for further investigations and management. On examination, otherwise a healthy baby whose weight and height was between 50th and the 75th centile was alert and active. Her vitals were stable. There was no pallor, no facial dysmorphism. Her head to toe examinations were unremarkable. On local examination, we found a polypoidal mass which was protruding out of vagina, which was reddish brown in color with few areas of blackish discoloration. The mass was around 88 centimeter in its longest diameter. There was no evidence of any inflammation. No inguinal lymph nodes were palpable. Per abdomen examination, there was no organomegaly. It was soft. The respiratory system and cardiac examinations were normal. We did the MRI of the child, which revealed a heterogeneously enhancing polypoidal mass. So this is the bladder. This we can see is uterus. This is the cervical lip, and this is vagina. So there was a heterogeneously enhancing lesion which had solid component as well as cystic component. The total craniocaudal extension was around 11 centimeter, whereas the intravaginal portion was around 5 centimeter. It was protruding outside the vagina. We did a biopsy of the child under anesthesia, which revealed a polypoidal mass covered by squamous epithelium. The subepithelial tissue showed proliferation of spindle to ovoid cells with hypochromatic nuclei. There were cross striations which were suggestive of skeletal muscle differentiation. There was mitosis, ulceration, and inflammation. So the findings were consistent with the diagnosis of botryoid rhabdomyosarcoma. We did IHC staining, which was positive for MyoD1, myogenin, desmin, and was negative for synaptophysin and cytokeratin. We did a staging workup, which included a CT chest, which showed no evidence of metastasis, and we did a bone marrow aspiration and biopsy, both of which were negative. So our final diagnosis was a botryoid rhabdomyosarcoma vagina. Since it was at a genitourinary site, non-bladder, non-prostate, with no nodal involvement and no metastasis, we staged it into stage 1. Since it was not resectable upfront, we put it into the group 3, clinical group 3. Since it was of embryonal histology, was of stage 1 and was a group 3, it came into low subset 2. After taking a consent for the treatment, we explained the parents about the prognosis and the disease, and we started chemotherapy as per our institutional protocol, which was IRS 5, which included 3 weekly VAC chemotherapy, which included vincristine, actinomycin D, and cyclophosphamide. So after 4 cycles of VAC chemotherapy, we did an interim MRI at 12 weeks. At 12 weeks, there was complete regression of the mass, which was seen in the previous study. Only residual thickening was seen in relation to vagina. So if we compare the before and the after images, the before image showed this heterogeneous mass, but in the after image, this is the uterus, this is cervix, and this is vagina. There was complete regression of the mass with only slight vaginal thickening. We did a biopsy from this side, which was negative for any malignant cell. So at evaluation at 12 weeks showed complete regression of mass with no disease. So we planned for the local therapy. We considered vaginal brachytherapy, which was delivered using a solver applicator, a total dose of 28 graboglibin in 5 fraction, 1 fraction per week, which was equivalent to 36 grays. So at 13 weeks, we gave the local therapy, which was brachytherapy. The further treatment, we continued with the adjuvant chemotherapy, IRS-5 back, and gave a total of 19 cycles and completed 39 weeks, total of 16 cycles and completed 39 weeks of chemotherapy. On follow-up, we evaluated the child 6 monthly, both physically as well as radiologically. On physical examination, the child was gaining weight adequately, was gaining height adequately as per the age, and radiological evidence showed no evidence of recurrence. We did examination under anesthesia with vaginoscopy, which also revealed no evidence of disease, and we even did vaginoscopy to break the synecdoche which were formed. The patient is 5 years off therapy and is doing well.
So thank you, Ayushi, for the case presentation. And now I may ask my experts if they have any question about the case from the Ayushi. They can ask if they need any clarification.
Can I?
Yeah, sure.
So Ayushi, thanks for the presentation. I had a query regarding the biopsy that was done after completion of your chemo, the induction chemo, the neoadjuvant chemo. So is that as a standard that you would do a biopsy, and how would your biopsy actually help you in So
actually, this biopsy helped us in deciding the dose for the radiotherapy, sir, brachytherapy. Since it was negative, we gave 36 gray. Had it been positive, we would have given 41 gray of radiation, sir. This is what our institution follows, sir.
okay, because as I understand, the histological changes that you would see, especially in rhabdomyosarcomas, while the treatment is still going on, could maybe not very clear indicator of whether there is disease or not. So I mean, you just have to be very careful about it when you're interpreting biopsies done just immediately after or during the treatment.
Right. So that is absolutely true. So Dr. Gori, Dr. Shalini, do you have any clarification that you want to ask? Otherwise, we can start the discussion actually.
So I think Dr. Lashkar's point is very well taken, and we had discussed this as well, because sometimes you may see rhabdomyoblasts which don't actually signify residual disease. So it is very tricky. Actually, I will tell you that there was some thickening and we were wondering whether being low risk, we should give radiation or not, etc., etc. And keeping all that in mind, we thought if we could see frank disease, we would give the higher dose of radiation, seeing the young age of the child. So very well taken point. You may actually go by radiological decision. So I think we can carry on. Dr. Shalini, did you have any questions? I think we can continue.
We can continue.
Okay. So let's start with Dr. Shalini. Dr. Shalini, when such a child like 1.5-year-old who presents with vaginal mass, what is your clinical differential diagnosis in such cases?
So you have to mute. So this particular child, I think the presentation is quite classical.
Ma'am, one of you will have to leave audio.
Dr. Sandeep, Dr. Shalini, are you in the same room? Then one of you is to clear.
Is it mute? Is it better now? Is it better now?
Ma'am, you need to change the room, or you can just leave the computer audio from the other device.
Dr. Sandeep is muted though.
But he needs to leave the computer audio.
So we need to be in a separate room. That's right.
No. Yeah, I'm here. Is it okay now?
Yes, ma'am, it's better.
So this particular child has a very classical
Ma'am, it's still
presentation.
echoing. Dr. Sandeep, can you just leave the computer audio from your device if you are in the same room?
Shalini has gone out. Now Shalini has actually gone out and we have changed the room. Should not be issue now.
All right. Okay, sir. Thank you.
Is it okay now?
Yes.
Okay. So this particular child actually has a very classical presentation, age group wise, of course, and also that polypoid botryoidal mass that we see. We always have to think about benign lesions first, especially in small children. So the appearance that Ayushi had shown the picture, we would definitely think about a hemangioma, although that's also very not a classical hemangioma. You don't see it like a polypoidal grape-like mass, the way it's like a bunch of grapes, what we call sarcoma botryoidis. So this is quite a classical thing, but still we have to rule out the benign lesions, maybe benign polyp, or sometimes a prolapsing ureterocele can also be seen, especially in newborn babies. but that'll have like a fleshy color, and it will be a single mass. It won't be like a bunch of grapes. And when we think about malignant conditions, which again come very high up on the differential diagnosis in such a child, the classical presentation, then of course rhabdomyosarcoma, and also we need to rule out a germ cell tumor. Sometimes we do see in this area, and rarely a vulval lesion. But those again will be mostly benign.
Actually, I came up with a study from St. Jude where they have shared their experience of vaginal tumor for last 30 years. So if you see, they just had like 18 cases in 30 years. It shows how rare this tumor is actually. And most of these tumors were actually malignant. Of these 18, 13 were rhabdomyosarcoma, 3 were germ cell tumor, and 2 were clear cell adenocarcinoma, which were seen in the older ages. I think Dr. Shalini has correctly pointed out that hemangioma and some other benign tumor may also occur, but overall the vaginal tumor in infancy and in young child is quite rare. So Dr. Shalini, next, how will you now investigate this patient actually?
So it depends on where this child has presented to. If it's in the periphery, definitely we would like to do an ultrasound. The problems in doing an ultrasound is that, you know, getting a full bladder for such a small baby may be difficult. But if we do manage to get a full bladder with a lot of patients and maybe a little bit of sedation, actually the radiologist can see through the bladder, and they can actually tell us about this, at least the cervical and the vaginal part of the tumor. Of course, basically to know the organ of origin. Subsequently, definitely we need better imaging to record what is the organ of origin and what is the extent and whether lymph nodes are involved. So an MRI would be the best thing, but that would be better to do it in an institute where the child is seeking further treatment, and also because it will require sedation, involvement of the anesthetist, and maybe a little bit more tricky because of such a small child.
Dr. Shalini, in addition to the organ of origin, what else do you think is important to see in the MRI from a clinical point of view?
So we need to see the local extent. And usually when we are thinking about vaginal rhabdomyosarcoma, usually it does not extend beyond the female genital tract. And of course, the lymph nodal drainage is higher up. It's in the iliac chain up to the renal hilum, the area where we usually do, the retroperitoneal nodes, the internal iliac, external iliac nodes, up to the renal hilum level. And that's what the area that we usually do when we do a RPLND, lymph node dissection. So that is the drainage, and that's the reason why we go up to the renal hilum in RPLND. If there is a vulval involvement, only then there will be inguinal lymph nodes. Otherwise, either is it bladder prostate, or it's paratesticular or vaginal. Usually the pelvic retroperitoneal nodes are involved. In vagina, again, it's below the common iliac nodes.
Yes, I think this is very important because this is an important part of staging. So we have to look at the regional node and their status. So Dr. Shalini, just one more question. Any comment on examination during anesthesia, and how do you actually ascertain organ of origin? Because sometimes what happens, a uterine tumor may actually fill up vagina. So how do you ascertain whether this is a vaginal tumor or a uterine tumor which has extended into the vagina?
Okay, so first of all, it's important to examine the child under anesthesia and not try to, with a wailing child, and we try to pull something and then it starts bleeding. And if the edge of the tumor which has come off, it retracts, and then we have a tough time controlling that bleeding. So they can be vascular also. So it's always good to do it under controlled conditions, under anesthesia, and we'll be able to evaluate it much better. And we are not going to trouble the child even. So what we do is we use a pediatric cystoscope, usually 7.5 or 9 French composite cystoscope is that what we use. And we go by the side of the polyp. very gently with the water flowing all the time to examine where exactly the origin of the polypoidal mass is, whether it's just the lower part of vagina, lower third of vagina, middle third, upper third, is a cervical fornix, anterior, posterior fornix, is it extending inside the uterus also, or is it coming from the uterus and extending into the vagina, which is very rare actually. So we can actually record the scopy findings, and we can even refer to it later at the time of radiation planning or when we are re-evaluating or re-scoping them to look at the response.
And how do you make sure that you take the representative tissue? A bulk of tissue actually outside may be totally necrotic. So how do you make sure that you get adequate tissue? Do you send sample for frozen section, or you can make out by your clinical examination that you have taken the adequate tissue?
So if there are any fleshy areas, we would like to take that definitely, and not just some cystic areas. And if we can take some tissue from the base of the polyp, that would be definitely better. Sometimes the parents will come with that grape-like thing which the child has passed, if it's not a very obvious mass prolapsing outside. And we can send it to pathology to see if they can make out something, but not always we may be able to get an answer. So the ideal situation, yes, we should send a frozen section. Sometimes telling us on the frozen section whether it is benign, malignant may be very difficult, but at least they can tell us that they have representative tissue and that they will be able to give us an answer in the next 48 hours.
Okay. I think that was very clear how to do the biopsy and how to ascertain the organ of origin. So anything the other experts who wants to comment about the biopsy or anything about the diagnosis, imaging and biopsy?
I think, Sandeep, you can reinforce about the age. The vaginal tumors occur in infancy, while the uterine tumors, they occur in the older children, more than 10 years.
Yes.
So in fact, knowing that helps, in planning the diagnostic workup.
That is right.
So that is important.
Yes, and in fact, in the COPE protocol, they have written that if you are trying to designate a patient with a vaginal site who is over 5 years of age, or a uterine tumor who is under 10 years of age, you should be doubly sure about it. Otherwise, there is clear-cut age-based distinction about the location of this tumor. And they say that the primary vaginal lesion must have evidence of visible tumor on the vaginal surface, which can be biopsied through the vagina. Displacement or distortion of the vagina doesn't mean that it's a vaginal tumor.
Good.
So now I move to Dr. Lashkar. Sir, why is it important to consult our radiotherapy colleague right at the time of diagnosis? Because most of the time, these patients actually either present to a pediatrician or to a surgeon. So, and we know that radiotherapy is an integral component of treatment, and why is it necessary to involve them right from the beginning?
So, yeah, it is, each one of us, the pediatric oncologist, surgeon, radiation oncologist, all of them are equally important. And the reason why it is important is because we know that once we have confirmed the diagnosis and we are treating these patients, as part of the treatment, local therapy is going to be a very important one. And to decide what kind of local therapy would be the ideal one, whether it is going to be surgery, whether it's going to be radiation, what is the possibility that you would be able to control disease, and what is the possible morbidity of the treatment that you're going to propose is best decided in a joint meeting when you are initially starting the treatment for that patient. So it is extremely important to have a radiation oncologist, surgeon, and of course the medical oncologist on board right from the beginning to decide what your local treatment is going to be. The second thing is regarding sequencing of therapy. So you cannot not sequence it right in the beginning, because once you've started your treatment, especially in conditions like us in India where we are constrained because of space and waiting appointments, it is very important that you schedule your treatment on time, because that is another very important factor. The other thing is regarding imaging. We were talking about imaging. what is the most ideal imaging. So the radiation oncologist would definitely want an MRI, not only to see the sites involved, but of course to see the extent of disease, not only within the vagina, but the disease extending beyond the vagina and the lymph nodes, because our treatment portals and the treatment volumes, the target volumes would change based on what you want to do. And of course, whether radiation is going to come into the picture or not, can we avoid radiation therapy completely? That would also be, based on certain investigations and certain things, like you mentioned here, the histological type. So there are many things that will be defined by who is sitting there. So it is important that we combine everything and take a decision.
That's right. I think adequacy of imaging from radiation point of view is very important component when we decide about the local therapy later on. So pre-treatment, extent of disease, status of the nodes, that is very important to know beforehand. Sir, what are different type of histological subtypes of rhabdomyosarcoma and their prognostic significance?
So yeah, I mean, it is thankfully it is relatively simple, and broadly you can have the favorable prognostic ones, and some people say that's the intermediate prognostic and some unfavorable. So broadly you can actually have two kinds, the favorable and unfavorable. So the one that we have here is obviously the favorable one, the botryoid rhabdomyosarcoma. You can have the spindle cell rhabdomyosarcomas, and they have 5-year survival rates of 85 to 95%. Embryonal rhabdomyosarcomas as a group would have a 5-year overall survival of, again, 75 to 80%. The not very good ones are the alveolars, the undifferentiated and anaplastic. And there's another group that we should not forget is the rhabdomyosarcoma with rhabdoid features. So broadly, you can classify them into these 4 groups, and because they determine the outcome of how the patient is going to do in the long run. So, and it also would define whether you can avoid a particular kind of therapy in these patients. Like if you have a favorable histology rhabdo and you can do a surgical resection, so you may be able to spare giving radiation therapy to this patient. Whereas if you have an unfavorable histology, irrespective of what kind of surgery or what group it is, you may have. Beyond that, you have other more fancy ones, the molecular tests, and we all keep talking about the PAX3 and the PAX7 FKHR translocations. So that again defines, and I will show in some of my slides later on, what is the significance. And there's a little bit of a controversy which is ongoing right now regarding the significance of PHO1 in deciding whether you can avoid radiation therapy in a group 1 favorable. So these are other tools that are very, very important in deciding prognosis and what kind of treatment you would want to do.
Sir, do you practice doing molecular testing for all your patients of rhabdomyosarcoma at TMH, or you like have selective only alveolar ones where you do this molecular testing?
No, we do for all our patients actually get a molecular test done here.
Okay. So what is the significance of doing this molecular testing for patients with embryonal rhabdomyosarcoma?
Embryonal, yeah. So yeah, it's primarily we do it for the alveolars, and embryonal is not really, if it's a clear-cut embryonal and there is no confusion in it, then you don't really have to do, because it doesn't really change your treatment protocols in any way. So embryonal, no. So primarily for the alveolar ones, it is a mandatory thing, yes. Embryonal you would do if there is a confusion, whether it's, if it's not matching completely with your diagnosis of rhabdomyosarcoma. Yes.
In the last 1 or 2 decades, we have seen that the clinical behavior and outcome of the patients is not determined just by the histology, but also by presence of this PHO1 fusion status. So patients with alveolar rhabdomyosarcoma, which are negative for this PHO1 fusion, actually they have
the same prognosis as embryonal.
And this has been shown in one of the Koch study. If you see the outcome of patient with embryonal rhabdomyosarcoma and alveolar with negative fusion is almost same, and as compared to alveolar which are fusion positive, and their outcome is much low. So
Yeah.
at least 20 to 30% of the patient with alveolar histology but negative fusion, so they behave as same as embryonal rhabdomyosarcoma.
So that has also added to a controversy regarding the the presence or absence of PHO, has added a controversy in group 1 alveolar rhabdomyosarcomas, and COG is currently looking at it. I'll show that in my slide later on.
Okay. So now may I come to Dr. Gauri Kapoor. Ma'am, what is the importance of site of tumor in pediatric rhabdomyosarcoma, and how do we stage and risk stratify these patients?
So once we have the diagnosis, then in pediatric solid tumors, it's very important not to rush in and start the treatment. So let me ask Ayushi, if you are still here, our fellow who presented the case. So what's the fun of doing staging, and what is its importance in clinical relevance?
Ma'am, it helps us in dividing, in putting the patient into risk group, whether they are low risk, intermediate or high risk. It helps in determining the prognosis as well as determining the treatment which is to be given in each group.
Right. So the intensity of treatment is determined by the stage, so that you know that the cancer treatments are very toxic and they do have late effects. So the whole concept is, let us give less treatment to those who don't require it and intensify treatment for those who have a more aggressive, more advanced disease. And we have clearly seen over these with various clinical trials, and especially the IRS trials from North America, as well as the European trials, that there is a subset that does excellent, and they define that as low risk, and there's a subset which is intermediate and another which is high risk. So rhabdomyosarcoma is very unique. It has different types of staging and classification systems. And one of the important things that is very relevant to the stage is site of disease. So as you see here, there are some favorable and some unfavorable sites, which are actually components of the final risk stratification and the staging. So unlike other diseases, there are sites which are very favorable, like orbit, then the non-parameningeal head and neck, the non-bladder prostate genitourinary, like in the present case, that is a vaginal and uterine would be those, and biliary tract. And the unfavorable are actually those where diagnosis is delayed because the site of origin is deep. You cannot see it, like a infratemporal fossa, and of course the extremity where the histology is unfavorable, and parameningeal, bladder prostate, of course. So if we move on to the next part, so site is important. Then there is something called the pre-chemo surgical pathological staging. So this is based on whether, so we have to remember that in rhabdomyosarcoma, like most solid tumors, it's a multidisciplinary treatment. There is a component which is called systemic chemotherapy, which actually is important for the micrometastatic disease, because we believe that rhabdomyosarcoma is an aggressive disease, and there is micrometastatic disease in almost all patients, even at presentation, and probably even for those with low risk or stage 1 disease. So systemic chemo is essential, but we also know that systemic chemo alone is not good enough, and we have to go local therapy. So in order to determine what kind of local therapy we have to give, we have this surgico-pathological staging, in which if the tumor is removed completely upfront, it is IRS clinical group 1, which are the patients, which is the only group actually where local treatment is given upfront. That is surgery, and they do not require radiotherapy. All the other patients who have either microscopic residual disease or gross residual disease will require radiotherapy as part of local treatment, with or without surgery. So we have to remember that. This is really, really important. So you see here, localized disease completely resected is clinical group 1. Very easy to remember, gross residue is clinical group 3, distant mets is clinical group 4, and all the rest, that is either microscopic residue, lymph node disease, lymph node removed or not removed, are all in group 2. So this is important to plan the treatment subsequently. So we hardly see the clinical group 1s, which are completely resected upfront and do not require radiation. All others require radiation, even if it is completely. This is just a general rule. There may be exceptions. There may be these ultra low risk where things, we are trying to avoid radiation, but more or less we can remember this. Then other than site now, what else is important? It is the surgical resectability and the TNM stage. In TNM stage, we take into consideration the site, size, presence of node, and metastasis. And here the histology and site. So the site is important. I will say, do not try to memorize it, but please refer to the book. Know that you have to stage, group, and risk stratify, and just open the book, because you can make mistakes if you try to memorize all these things. So if we see the next slide, we see this is the risk stratification. After we stage them, then we risk stratify them. So we have low risk, intermediate risk, high risk, which now in the current trial, they are trying to make it only into 2 groups, or maybe we will see how that goes. So to remember what does the risk group include? It includes the site, because it has a stage. It includes the histology. So if you try to remember the risk stratification, remember low risk, only embryonal histology. Alveolar can never be low risk. So embryonal will either be intermediate or high risk. All stage 4 are high risk, irrespective of histology, right? Now let's go to the clinical group 3, or let's look at the all clinical group 1 and 2. Embryonal will be low risk unless they are not of the orbit. So all alveolar, if they are not metastatic, will be intermediate. Doesn't matter anything, right? Low risk alveolar can never be low risk. So site is important, histology important, and then of course the nodal and many things are there. So in our case, this is a vaginal rhabdo. It's a favorable site. It is embryonal or botroids. It is a favorable histology. Nodes were negative, right? So all of this make it, what does it make it? Ayushi, what does it make it?
Stage 1.
Stage 1, subset 2. Because it is clinical group 3. So it is clinical group 3, node negative, and embryonal histology.
Right.
Okay. So try to look at the book and try to put it wherever it is. So if we see the next slide in staging, what all we did in staging, and Sandeep, can I have the next one? Right. So now the controversy is PET to PET or not to PET, and in India, to PET is the norm. However, even today, sometimes we do the local imaging, which is a pelvis and abdomen is always in that in children. So we do bone marrow and we do CT chest, but many children also get PET scan. And what is the advantage of PET? There are 2 or 3 advantages. One is that you can know whether the node is positive or not, because in a CT or an MRI, you will just see the size of the node, but you may not be able to determine whether there is whether it is having disease or not. So that is one thing. Second is, you can also, there may be other potential sites of disease which you would have missed. And thirdly, you can also see the response assessment. So all the 3 things are there, because now they're also having studies where if after 4 cycles, the response is PET negative, then you have to decide about the local therapy, either to give or not to give, or to determine the dose. So the current COG studies, can I have the next slide, are also looking at reduction of RT dose based on PET, and also that PET is not mandatory, but if you are trying to collect data about the patients and their outcomes, then PET data would be really useful. But you should do upfront PET and then at evaluation, so as to have more data on how the patients are faring. Next one. So marrow. So really, we are doing marrow in every patient, a marrow aspirate and a marrow biopsy. So the things that we do a CT chest and we do a bone marrow aspirate and biopsy for staging. If a PET is there, even then we are doing a bone marrow biopsy. But there's data to show that if embryonal tumors are there, small tumors are there, nodes are not negative, probably marrow may not be required. And chance of bone or bone marrow PETs is very, very less. So in COG, they are not doing it, but we are doing so far. But it is possible that in the years to come, with more data coming in, we may skip it. Just like in Hodgkin's 1A, we are not doing marrow. I think as the data grows, the confidence amongst the clinicians for avoiding marrow would be there. Sandeep, did we have any other issues on staging?
I think you have covered most of the things, and the controversy was about the PET scan and bone marrow, and you have tried to simplify that. I think if there's any question from anybody else about the staging and biopsy and staging, then we may take up that question. Otherwise, we can move forward. Dr. Shalini, Dr. Lashkar, anything else you want to add?
I think we are okay.
Okay. So now after the staging, next is now about the treatment. So most of this patient actually will require neoadjuvant chemotherapy. So may I ask Dr. Bori to tell us about the principles of chemotherapy in rhabdomyosarcoma?
So like for all pediatric solid tumors, so pediatric solid tumors are aggressive. We use multiple agents. The backbone is always of systemic chemotherapy, and local control is an important component of curative treatment, and the sequence is extremely important. The time frame is extremely important. We have to plan it upfront so that the surgeon and the radiation oncologists are on board. They know when the local therapy will be required and therefore schedule it accordingly. This is like critical. We can't just do chemo and then tomorrow radiation is due or some surgery is due and you send a reference. That will not do. So this is very, very important if we want to have good outcomes. Then we also remember that the alkylating vincristine and an alkylator are part of most pediatric solid tumors. And the three most, what shall I say, the active agents are vincristine, actinomycin D, and cyclophosphamide, which have been actually in last, I think, 3 or 4 decades. The first IRS trial used these 3 drugs. And even today, we are using the same 3 drugs. But we are trying to fine tune the doses of alkylator. We are trying to see whether doxorubicin is required or not, whether irinotecan is required, and so many new things, because for stage 4, we are still figuring out what to do. So the important thing is that we do 4 cycles of chemo every 3 weeks with weekly vincristine for the first 10 weeks. And then we do a response assessment between 11 and 12 weeks. So for 4 cycles every 3 weeks, which is 0, 3, 6, 9, and at 11 we do the evaluation. So this is standard. We try not to give the 5th cycle before local control. Some people say that the response after 4 cycles is suboptimal. Should I give 1 or 2 more cycles? Maybe it will reduce. That is incorrect. It is believed that maximum reduction in the tumor will occur with first 4 cycles. And if it is not further reducing, and you have given adequate doses with the correct time frame, probably there is a resistant clone there which requires the local therapy, which may be surgery, radiation, or both. Remember again, surgery and radiation are required for clinical group 2 and 3 patients as a general rule, except for certain, very few exceptions. So this is the current COG, what they're trying to do for the ultra low risk. Everybody knows that cyclophosphamide has late effects, which are second malignancy and infertility, in addition to many others. So to reduce these 2 for the ultra low risk, they are trying to just either do VAC 4 cycles because the cumulative dose of cyclo will be less, and other group where they may have only 2 drugs for 12 weeks. So VAC for 4 cycles followed by VA for 4 cycles, or VA for 12 weeks for the low risk. You might know that when we did VAC for 14 cycles up to 42 weeks with the IRS-5, we were giving cyclo 2.2 grams per meter square. And we were giving 14 cycles, and the cumulative dose of cyclo was 30 grams per meter square, 30.4. But now in the last 5 years or 8 years, the dose of cyclo IRS have reduced it to 1.2 grams per meter square, which we are also using. But even 1.2 will give a cumulative dose of, I think, about 26 to 28 grams per meter square. We know that infertility is caused, I think I will not tell that now. Infertility is caused by a pretty medium dose of cyclophosphamide. So the other thing to see is our patient is low risk. We treated this patient as intermediate risk, and we gave 3 weekly VAC for 40 weeks. That was in about 8 years ago or 6 years ago. So, but now we know that we can actually give them less treatment. So you can see that ifosfamide, etoposide, irinotecan, these are other drugs which are being tried in the intermediate risk and the high risk. And the whole idea is, can we reduce cumulative dose of alkylator? By throwing in irinotecan and by trying to reduce the dose of cyclo, we are trying to reduce cumulative dose of alkylator. Sandeep?
I think you have summarized it very nicely. And I think initial focus of all the trials is to improve the failure-free survival. And once you achieve a desired failure-free survival, then they focus on reducing the late toxicities. And in low-risk RMS, probably now that is the theme, how to reduce the long-term toxicity. Thank you, ma'am. So, ma'am, any special precaution for infants when you treat them? Because they may have like some...
So for infants, the main thing, 2 things to remember, they have immature livers and they have large surface area. So dosing is kept per kg. So most protocols will have a separate table for per kg dosing. And second thing about the concurrent with radiation. So the important thing is when we give surgery, when we do surgery, of course, there is no concurrent chemo, but everybody knows that radiation spans over a period of 4 to 6 weeks. So since this is a disease which is having micromets from beginning, it is hematogenous, we must give some amount of chemo even during that period. So the important thing is there are drugs like actinomycin D, which are radiosensitizers, can cause local reactions. So we do not give actinomycin during radiotherapy treatments. So usually 48 hours from the last dose of actinomycin. So if you're doing VAC, you can give VAC and do not start radiation before 48 hours. During the radiation, no actino. So only give vincristine, cyclo or ifosfamide, whichever is your protocol. And then after radiation is completed, you can once again give the actinomycin. So this is important to remember. Even doxo is radiation sensitizer. So we do not give doxo during radiotherapy.
I think that is a very important message. And the other thing is we should not discontinue chemotherapy during local therapy. That is also one thing. Many times, many centers actually discontinue VC during radiation, but that should not be practiced. Only actinomycin has to be kept on hold, and rest of the 2 drugs can be given during radiation. So now let's come to the...
Sandeep, can I just add a quick point here? You know, Gauri brought about a very important aspect about sequencing radiotherapy and actinomycin D. Now, both doxorubicin and actinomycin D accentuates radiation adverse effects. But the more dreaded thing about actinomycin D is the radiation recall phenomenon. So paradoxically, although we are not using actinomycin D while radiation is going on, really speaking, the radiation recall phenomenon is something that happens in a patient who has actually finished radiation. And then when you give actinomycin D, the area that was radiated shows accentuated radiation effects. So it is a little bit of a paradoxical thing there. But yes, generally we need to be careful about it. So in a way, what I'm trying to add to what Gauri has already said is that you could expect a radiation recall phenomenon in patients who have actually finished radiation therapy. And few months after that, when you're doing your actinomycin D, that's the chemo, that's the time when you have radiation recall and reactions. So that can happen. We actually had that in one of our patients, and that was probably known to everybody in the country because it went for a long time. Yeah.
And Dr. Lashkar,
Starting,
that's what I wanted to ask.
In this room, my nurse is already there. They'll start now.
So there was one more question quickly from the participant. They said cyclo
They'll
bladder radiation may cause hemorrhagic cystitis.
Yeah, of course. Yes. So it depends which site we are treating. So, and that is why we need to be in collaboration with the treating medical and radiation oncologists. So cyclophosphamide definitely increases the bladder toxicity. So we have to be very careful.
And sir, how much gap do you keep after completion of radiation therapy to for actinomycin or doxorubicin to be restarted?
So you could actually start immediately, but
Okay.
you just need to be aware of the adverse events that can happen, because there is no way you can predict whether a particular patient will develop radiation recall phenomenon. So it's completely, I mean, you just have to be aware of that.
Ma'am, there is a question from the participants actually that if response is suboptimal after 4 cycles of chemotherapy and local therapy is not technically feasible, should we upgrade to higher risk chemotherapy?
So, sorry, if the response is suboptimal, so can we say what is optimal response? Or what, PR, less than PR, what are we thinking? And what is the site?
So that was not clear from the participants. So say example, it is like 40% reduction from the initial tumor volume, and surgical resection, RGO resection is not possible. So would you go for radiotherapy, or would you try to give more chemotherapy to make it amenable to surgery and radiation later on?
I think what we discussed earlier, what Lashkar also said, that are there rhabdomyoblasts over there? Is it like a maturing rhabdo? What is over there? So we need to know that.
Okay.
So a good biopsy would be, firstly, we have to make sure did they get the right doses and did they get it at the right interval. And then I think if there is a residual disease, we should biopsy to be sure that there is something. If there's a big tumor there, there's good chance it is active. But if they're just rhabdomyoblasts and necrosis, then I think that we should try to go for local control. I will prefer rather than trying to push chemotherapy.
I think that is right, and this message is very, very clear. The maximum tumor kill occur in the first 4 cycles of chemotherapy, and by after achieving this, it is time for local therapy here. Okay, now let's move to local therapy for this case. Dr. Shalini, in this case, in the vaginal rhabdomyosarcoma, what do you think is the role of surgery? Like in this patient who had like a IRS group 3 kind of tumor, and after neoadjuvant chemotherapy, it has regressed very significantly. Only a thickening is seen in the vaginal wall. So now, what do you think about the role of surgery in this patient?
So in the current practice, the role of surgery for local control of rhabdomyosarcoma is very, very minimal. Most of the times, because it's a very chemosensitive and very radiosensitive tumor, it responds beautifully with the chemo, as we have seen here itself in the first 4 cycles of chemo. And the other thing is that doing surgery for a vaginal rhabdomyosarcoma to get a negative margin so that we can get some benefit of not giving radiation is going to be a very morbid surgery. So like way back in the 70s, they were doing pelvic exentration for all the patients with vagina, all the children with the vaginal rhabdomyosarcoma. So as we can see in this study, although it's a little old one, but it tells us everything about the experience of IRS 1 to 4 about the role of surgical management of vaginal rhabdomyosarcoma by Andresi. So a total of 72 patients with localized vaginal rhabdomyosarcoma. Of course, they excluded the stage 4 ones over a period of 25 years. And so they saw that each successive IRSG trial resulted in a decrease in the need for surgical resection. So way back at the time of IRS 1 in the 1972 or so, 100% all patients were getting surgery up front. And gradually, during IRS 2, about 70% received surgery. And then IRS 3, only 30% received surgery. And among these 30% who actually they gave neoadjuvant chemotherapy, and after that there were about 7 patients in whom they operated, did the surgery after giving neoadjuvant chemotherapy. And they realized that 6 of them showed no viable tumor, and the 7th one showed only some mature rhabdomyoblasts. So that's how gradually we have come out of it, that we are not going to perform a morbid surgery unless the tumor is not responding or it's a recurrent disease. So that is only about 13% of the patients in which we now go in for surgery. In fact, I have of late, I mean, in the last 20 years, I have not done a vaginectomy for a child with vaginal rhabdomyosarcoma. So occasionally we may have to do, how we do go in pediatric oncology, that organ preservation is utmost importance, of course, without compromising the oncological principles. And again, I think we have a very good means of giving a brachytherapy, radiation, which does not have too much of side effects for this child, because it's a young child. In giving radiation also, we are a little concerned. And this doesn't have too much of side effects on the growth, and chemo is very chemosensitive. So a very minimal role of surgery. Of course, we need to go in periodically and do a surveillance and sometimes do a biopsy, because as you saw in the initial response itself, you can hardly make out that there's just some thickening on the MRI. So repeated MRIs also, we may not be able to get much, but of course we need to do a scopy, we record it, we compare it with the previous ones. And if any suspicious areas are there, we do a biopsy. So if we see that there is some mature rhabdomyoblast, that is nothing much to worry. We do not consider it as an active tumor at all.
So now can we move to Dr. Lashkar? What is role of radiotherapy for local control in this patient? And what will be the mode of radiotherapy, dose, and what are the challenges to deliver this radiotherapy in a very small child?
So like we discussed, in this patient with a very good prognosis, very good outcome that we are expecting, we need to choose a local treatment modality which will give us good local control, at the same time avoid unnecessary adverse effects in the acute or in the long run. So surgery would be morbid without much substantial benefit. So the local treatment of choice, especially for this child, would be definitely radiation therapy. Like we all know, radiation therapy has its own side effects, both acute and late. We are more worried about late side effects in these young kids. And these late side effects are to do with the vagina, with the surrounding normal tissues, which is bladder and rectum. We are worried about the bone growth. And the other most dreaded is the second malignancy. So we need to keep in mind whatever radiation therapy technique we do, we try to do it in such a way that we reduce these possible acute and late side effects. Now, in this child who has disease confined to the vagina without any perivaginal extent of disease, and when there is no lymph nodal disease, our target volume in our radiotherapy terms would be just the vaginal mucosa and the immediate vaginal tissue surrounding it, without requiring to treat the perivaginal tissue. And this can be very easily done with brachytherapy, like both Shalini and Gauri mentioned. So this can be easily done with intracavitary brachytherapy, where the dose is confined there. And literally there will be 0 dose to the bladder and rectum, and also to the bony pelvis. And the volume, total volume of normal tissue also that will be radiated will be less. And that would potentially reduce the chances of second cancers in the future. So, and if you look at the long-term outcomes of second cancer in these patients who receive external RT, is about, in the range of 6 to 10% based on what were the other agents that were used along with radiation and what was the volume. So that is the thing. So in this patient, we will definitely advise brachytherapy, intracavitary brachytherapy, which was actually done for this child. The dose of radiation, when you're doing definitive radiation, not post-operative, needs to be a 50 gray equivalent. That is 5,000 centigrade equivalent. So if you're doing brachytherapy, you have to divide your dose in such a way that the total cumulative equivalent dose is close to about 50 gray, because there's no surgery done. Now I had a question regarding this patient who had 36 gray, but the dose per fraction was 5 gray per fraction in intracavitary, and you had given 1 fraction per week. Now, what is known in radiotherapy things is that the moment you increase the dose per fraction, the late effects increase. So in children, you should always keep the dose per fraction to as small as possible.
Okay.
And the second thing is, when you give a gap of 1 week, the biological efficacy also is lost to an extent. So we are lucky that this patient did well, but you did mention that this patient had synechia after 5-6 years, which were easily broken. But possibly, if you did 2 gray per fraction instead of 5 gray per fraction, 1 fraction per week, possibly the results would have been same in terms of local control, but the late effect in the form of synechia would probably not have been there. So that's about brachy. If you don't have brachy, external RT is definitely an option, and there are ways to deliver very focal external RT to small volumes using the currently available treatment modalities. So just in case somebody doesn't have the facility or the expertise for brachy, you do have the option of doing external beam radiation therapy. So yeah, I mean, that's a good point. Monica has written, what is the role of ovarian transposition? Definitely. In these young girls, ovarian transposition is very, very important. And just one thing that one needs to remember is that ovarian transposition doesn't mean transposing the ovaries behind the uterus. It needs to go out of the planned radiotherapy field. So you can probably put it in the gutters higher up. So again, there has to be a dialogue between the surgeon, medical oncologist, and the radiation oncologist. So good point, Monica. And yeah, one of the challenges in an infant is obviously about anesthesia. So you have to have a setup where you can give anesthesia to a child every day for the treatment. Yes. Yeah, there is a question here which says, is there any subset of vaginal rhabdomyosarcoma where you would omit? Well, the best subset of vaginal rhabdomyosarcoma are the botryoid rhabdomyosarcomas. And in them, if you have a complete response, I would end up giving brachytherapy. So if you're asking me whether you will avoid radiation therapy, I would not avoid radiation therapy. I would probably look for a good way of delivering radiation therapy. And so I was talking about external radiation. If you don't have brachy, nowadays you will have protons also, theoretically speaking. And people have treated macular tumors with protons. So there is no way you cannot treat a vaginal tumor with protons and spare the surrounding normal structures. So
actually, that was the next question, actually.
Yeah. So yes, see, the proton is not magic. The proton is simply like any other external RT technique or technology. The only benefit of proton is that your ability to spare the surrounding normal structures is better. It is biologically not superior to X-rays. So 50 gray of X-rays is not inferior to 50 gray of proton. But 50 gray of X-ray would cause more damage to surrounding normal tissues than 50 gray of protons, possibly if you've planned it well. So proton definitely has a role to play in these young people. And if you ask me, are you going to not do radiation therapy in any of them? I would definitely do radiation therapy. I may not do if it is palliative, progressive, and I would just do palliative RT. But in a curative setting, in today's age, with the tools that we have, we should do. And there is data to show, there is data from the Children's Oncology group to show that the outcomes are much superior, both from the DR 9602 and the other study of COG, that outcomes are better. So I would definitely recommend radiation, but choose the right radiation.
Okay. In fact, I think there are two approaches about the indication of radiotherapy in vaginal rhabdomyosarcoma. In the COG approach, in the IRS group 3, every child should receive radiotherapy. There is no doubt about it. But in the European approach, what they are doing after neoadjuvant chemotherapy, if the child has complete response, they prove it by either biopsy or with negative PET scan. Then they are trying to omit RT So they will have more events, but definitely their failure-free survival will be lower. But they think most of these children are actually salvageable later on, and therefore overall survival will not be affected. So there is a difference in philosophy. I think we will cover this in the talk also. But from the core point of view, anybody who is IRS3, radiation is must. And probably they have tried to omit RT for a subset of patients, and they have burned their finger, and failure-free survival was much lower. So,
So Sandeep, we move on to the didactic. I think we can skip this.
okay.
I think because this time is running out, I think Sunil will want us to wind up by 5:30. So I think we quickly do the two didactics, and then we can take more questions if Sunil allows us.
Okay, sure. I'm just opening my PPT for.
So meanwhile, if there are any, let me see, are there any questions which we can do while the slides are opening up? Any of the other experts want to add anything while Sandeep is opening his slides?
Can you see my slides?
I think you have to share screen. Or have you shared? Yeah, we see your slides.
Okay. So we have discussed many aspects of management of rhabdomyosarcoma. I shall be just updating in few slides about what we have learned so far in low-risk rhabdomyosarcoma. So we know that rhabdomyosarcoma is the most common soft tissue sarcoma in children, and it accounts for 3.5% of childhood cancer. Well-designed systemic cooperative trials from North America and Europe, along with advances in the multimodality care, has resulted in immense improvement in failure-free survival of these children with RMS. So if we look at this graph before start of this IRS clinical trial, the outcome was just 20%, and it has improved to around 80% after the IRS 5. And if we look at the low risk subset of this, the failure-free survival is 90% and overall survival is close to 100%, which is so impressive. So now the next question is, why do we need to identify this low risk patient? So we know that they have very good outcome. So we need to optimize their overall quality of survival. And how can we do this? This we can do by reducing the long-term and acute toxicity. So we need to identify this patient. Then there also we need to simplify their treatment as much as possible and to reduce the cost so that the abandonment is on the lower side. So the next question is, what is low-risk rhabdomyosarcoma? So conventionally, low-risk rhabdomyosarcoma has been defined as patient having a 5-year failure-free survival of approximately 85% in IRS3 and IRS4 studies. So to categorize somebody as low risk, they should have two things. One, the tumor should be non-metastatic and it should be of embryonal histology. These two are like prerequisites. Without this, you cannot have low-risk rhabdomyosarcoma. Then based on certain other features, this low-risk rhabdomyosarcoma has been divided into subset 1 and subset 2. Subset 1 is ultra low risk, which has been completely resected in the favorable site. And if it is not completely resected and is in the favorable site, it is in the subset 2. In the unfavorable site, subset 1 has to have complete resection along with less than 5 centimeter tumor size, and there should not be any regional nodes. But if the tumor is more than 5 centimeter or there are regional nodes, then it is subset 2. I know that this classification sometimes may be complex, and as Dr. Gori initially told also, if you have some doubt, you must verify it in the textbook so that you don't make a mistake in classifying some intermediate as low risk patients. So now how can we optimize treatment for these patients? So in terms of chemotherapy, we know the active agents are vincristine, actino, and cyclo. Inotican and doxorubicin are generally reserved for intermediate and high risk patients. So most common agent that is associated with the acute and long-term toxicity in low risk rhabdomyosarcoma is alkylating agent, which is either cyclo in the North American protocol and ifosfamide in the European protocol. So the main focus of this trial is to reduce the dose of alkylating agent. In local therapy, we have two modalities: surgery, radiation, or combination of two. Surgery always has principle of like achieving a arch-to resection without compromising the function of the organ. And in radiotherapy, we are either trying to decrease the dose or we are trying to incorporate newer techniques so as to reduce the side effects to the normal tissue. So whenever we are modulating with the dose of chemotherapy or dose of radiotherapy, we always run a risk of compromising the excellent failure-free survival that we have achieved so far in these children. So all this actually should be tried in well-designed clinical trials. So if we look at the historical treatment for low-risk rhabdomyosarcoma, the attempt to remove cyclophosphamide from the chemotherapy protocol started as early as in IRS-3. And the resultant failure-free survival was 83% for subset A and 70% for subset B, which was much less compared to the historical control. So in IRS-4, they again introduced cyclophosphamide at the dose of 2.2 gram per meter square, and the outcome of subset A improved by 10% and outcome of B improved to 14%. So it was very clear that addition of alkylating agent like cyclophosphamide is essential not only for local control but also for the systemic control. So in IRS-5, actually they sought to reduce or to omit this cyclophosphamide only for subset 1, and they continued for subset 2, and the resultant survival that they achieved was desirable. With the knowledge and experience they gained from these IRS study, RMS COG group actually designed this study ARS-30331, where they tried to use the modest dose of cyclophosphamide. By modest dose, I mean 4 cycles of neoadjuvant chemotherapy at the dose of 1.2 gram per meter square. So cumulative dose was 4.8 gram per meter square, and it was much lesser compared to 26.4 gram per meter square in the previous trials. So dose of cyclo was reduced. And also, if you see, the duration of treatment is also reduced. From the 42 weeks, it is reduced to 24 weeks. And this reduction in the duration of therapy was based on the MMT and the German studies. In addition to chemotherapy, they also reduced the dose of radiotherapy. For IRS-2 group, they reduced from 41 gray to 36 gray. And for group 3 orbital tumor, they reduced the dose of radiotherapy from 50 to 45 gray. And let's see what was the outcome. So total 271 patients were enrolled in subset 1. Failure-free survival was 89% and an impressive overall survival of 98% was achieved. In the subset analysis, they found that the paratesticular tumor had the best prognosis, close to 100%. The one group that did not fare that well was orbital group, and they had like 11.5% local failure. So what they concluded, shorter duration of treatment, that is like 24 weeks, that include the lower dose of cyclophosphamide, that is 4.8 gram per meter square, and lower dose of radiotherapy. It did not compromise the failure-free survival for patients with subset 1 rhabdomyosarcoma. So they did a subset analysis for this orbital group patient who did not have that good outcome. So total 53 patients were actually included in this subset 1. And of this 53, 15 patients achieved complete remission at week 13 after neoadjuvant chemotherapy. And of these 15 patients, none of them had local recurrence. But of the 38 patients who had partial response after neoadjuvant chemotherapy, 6 suffered local recurrence, and that is around close to 16%. So they concluded that initial response to chemotherapy is predicting the outcome for orbital rhabdomyosarcoma. So for patients, those who do not achieve complete remission after neoadjuvant chemotherapy on radiology examination, the radiation therapy dose should not be decreased, and they should be given 50 gray, and 45 gray is not sufficient for them. So in the current protocol, they have increased dose for these patients to 50 gray. So this was one learning. Now let's look at the result for subset 2. In subset 2, the neoadjuvant chemotherapy was same, and so was the dose of cyclophosphamide, 4.8 gram per meter square, but the duration of treatment was 48 weeks instead of 24 weeks that was in the subset 1. There was one major modification in the indication of radiotherapy for these patients. For less than 2 years of age, for patients with the genitourinary RMS, the indication or the radiation therapy protocol deviation was allowed at the discretion of the treating physician if they think that they are concerned about the long-term morbidity of radiotherapy. So this was like major decision that they had taken in this protocol to reduce the long-term side effect. This trial started in 2004. However, it was suspended in the 2008. It was because of these results. In the interim analysis, there were 16 patients with vaginal rhabdomyosarcoma. They were not given radiotherapy, and they had a local failure of 42%, which was totally unacceptable. So the protocol was amended, and for all group 3 vaginal tumor, actually indication of radiation was changed, and the trial was reopened after 1.5 years. But in the second interim analysis, what they found that the failure-free survival for almost all the patients was not as they expected, and the trial was prematurely closed in 2011. And here are the final results. Total 66 patients were recruited in the subset 2, and 3-year failure-free survival was just 70%. And there were 20 failures compared to what they expected, 10.5. So they concluded that the reduction of cyclophosphamide for subset 2 is not feasible. And in the current study, actually, this subset 2 is being treated as intermediate risk rhabdomyosarcoma. They are no longer low risk rhabdomyosarcoma in the full study. So this is a slide which highlights the importance of protocol-specified radiotherapy in these children. In patients less than 2 years, where the decision for radiotherapy was at the discretion of the physician, the chances of local failure were much higher compared to children, those who were more than 2 years. And this difference was like 35% versus 16%, which was significant. So clearly protocol-based radiotherapy is must for good outcome. So just one slide about what is the difference in the North American and European approach in the low risk. We have discussed it during discussion also. One major difference is they use ifosfamide as alkylating agent in place of cyclophosphamide in the North American protocol. And in radiotherapy, they are omitting radiotherapy in low risk patient if they achieve complete remission with chemotherapy. So impact of this approach is the patient, those who do not get radiotherapy, they will have lesser acute and late effect, and which do not suffer event. But definitely when you are excluding radiotherapy, there will be more event, and there will be significant late morbidity in those who suffer events, because they will receive more intensive chemotherapy and more higher doses of radiotherapy also. But probably the endpoint in these studies is different, and primary endpoint is actually met with both the approaches, because in Koch studies, the primary endpoint is failure-free survival and overall survival in the European studies, and overall survival is same with both the approaches. So when the OS is same with both the approaches, the impact of the differences in the philosophical approach of this study design can only be understood if we have studies on the quality of life of these survivors, which is not available right now in the literature. So just to conclude that we have achieved excellent cure rate for low risk rhabdomyosarcoma. The current focus is on reducing the long-term toxicities. There is a strong interdependence between the cumulative dose of cyclophosphamide, radiotherapy, and failure-free survival. Dose of chemotherapy and radiotherapy can be safely reduced in subset 1. However, this is not so for subset 2, and we need to fine-tune this in the future trials. Thank you. So this was like an update on rhabdomyosarcoma from chemotherapy point of view, what we have learned so far, and how we have moved from 2.2 gram per meter square, that is cumulative dose of 30 gram per meter square, to 4.8 gram per meter square, at least for subset 1. If there are no more questions, we can move to the second lecture. Anything, ma'am?
No, I think we'll do Dr. Lashkar's talk, and then if there are questions, we can jointly take them. If Dr. Sunil permits, or there is more time.
Okay. So I guess
I think Siddharth, you should start your presentation.
Yeah, I think we'll quickly finish off. I hope I'm visible.
Yes.
So my idea was to, just straight away talk about what are the indications, when should you do radiation therapy, and what dose should you do? Is there a change in the target volume, because it has such an implication on the later effects that we can have? Can we de-escalate the doses? Do we need to escalate the doses of radiation? Does hyperfractionated radiation help you? And can we really avoid radiotherapy in some very young kids? And does the fancy techniques that we have an impact on the outcomes of radiotherapy? So to broadly put it, when do we use radiation therapy? With the current evidence that is available, we do it when the disease is not upfront resectable, which is group 3. When you have left behind disease microscopically or gross after surgery, or you have resected the tumor well, but unfortunately the patient has not a very favorable histology, which is alveolar. I'll come to the things. Timing, when do we do radiation therapy? Now, the timing of radiotherapy, the evidence is not available for extremities. We just base it on what we do for the parameningeals and the head and neck rhabdomyosarcomas. And whatever evidence is available is all from the studies of the head and neck rhabdomyosarcomas rather than extremity or other site rhabdomyosarcomas. And based on that, we actually define that is one of the factors based on which we define when radiation should be given. There's not much time, but patients with with intracranial extension, cranial nerve palsies, and base of skull involvement, we need to start radiation upfront. When there are chances of spreading of disease in the intracranial sites, in them, that is the parameningeal sites, we need to start at week 3. And all others, we would prefer to start radiation after you finish the more intense chemotherapy, which is week 9 in the IRS protocols. So that's about the timing. When should you start? The question comes, can we really avoid radiation therapy in some of them? I just jotted down some studies based on which we can probably infer whether it is safe or not. Again, from the MMT protocol, the PSYOP MMT protocols, people did try to avoid radiation in very young kids, less than 3 years, 2 years. And the overall survival differences were significant. Almost 60% overall survival when you did, and you had 44% when you did not. So there was a significant difference. So unless your morbidity is going to be so much that you can compromise almost about 20-25% of survival difference, it is not suggested that you should avoid radiation therapy in these patients. This also applies to rhabdomyosarcomas of the vagina. And so avoiding radiation therapy is really not possible. I will go slightly quick here. This is a recent publication from the Children's Oncology Group. Here, they wanted to use FOXO1 fusion status as a factor that would determine whether you can avoid giving radiation therapy in a group 1 favorable alveolar rhabdomyosarcoma. So what was seen in these patients is that this was not randomized, but they did use, as per the physician's discretion, in some patients, and in some patients they did not. And the broad thing that you see, if you look at the outcomes, 4-year local control for all, the entire group of these 3 important studies from COG, which are pretty recent, is 17.1%. And if you look at the entire group put together, the ones who did receive radiation therapy had local failures of 4.9%. And the ones who did not receive radiation therapy, the local failures was 34%. So there was a 30% increase in local control for the whole group. And when they looked at, based on whether this patient was FOXO positive or negative, the ones who were positive and did not receive RT had inferior outcomes compared to the ones who had FOXO negative. And that is what we were talking right in the beginning when we said the FOXO negative alveolar rhabdomyosarcomas are possibly similar to the embryonal rhabdomyosarcomas. So that's the significance of FOXO when you're trying to avoid radiation therapy in these patients. But there is a catch there. The catch is that the local failure is definitely better. The reason why the Children's Oncology Group ended up saying that possibly you can avoid in FOXO negative, avoid RT in FOXO negative, that is based on the results of the event-free survivals. Now, event-free survival is because you've got disease, which is metastasis. Now, when you do radiation therapy, it is primarily to improve local control. It is not possibly going to, and it may possibly translate into an improvement in overall survival. But that is the catch that I want to show in this paper. And all of us, when we are looking at it, we will straight away say, oh, COG says that event-free survival is not different whether you add radiation therapy or not. But radiation is not going to really change the event-free survival. That is probably the chemo that is going to change the event-free survival and not radiation. But the local controls are better. So this is a very important study that has come just recently in February this year. So I thought it is important. So can we avoid radiotherapy in group 1, low risk, alveolar rhabdomyosarcoma? The event-free survival is better, but local control wise, you cannot avoid. That's the data that is available right now. I mean, this is very recent data. This is the other one I was talking about, the vaginal rhabdomyosarcomas. This is again from Children's Oncology Group. All good studies, the ARST, it's not actually 531, it is the 331 study. And the reason for inferior local controls in ARST 331 was attributed to avoidance of radiotherapy and lowered cyclophosphamide dosage. So I actually had a question for all of you that, they were trying to reduce the dose of cyclophosphamide from 2.2 to 1.2, but it has an implication in local control. So we need to strike the right balance between reducing the dose of cyclophosphamide to compromising local control. So that's important. So in vaginal rhabdomyosarcomas in the young kids, it is better not to avoid radiation therapy because there's a huge difference in local control. I will skip the volumes part because I don't think there are many radiation oncologists here, but this is just to tell you what volumes. The doses we discussed a little bit. If we are doing definitive radiation therapy, that means without surgery, the standard doses is 50.4 gray. If you are doing surgery followed by radiation therapy, it's 41.4 gray. But people have tried to reduce the dose of radiation. Like Sandeep mentioned in this 9602 study, they tried to reduce the dose in the favorable group to 36 gray in the stage 2, that's microscopic positive. And in the others, they kept it 45 and 50. In orbit, it is favorable, so kept it 45. In the non-orbit, they kept it at 50 gray. Let us see what happened. When the chemotherapy that you used had an impact on the local controls with radiation. In 9602, when you give 36 gray and you did not have cyclophosphamide, the local failures were 15%. Whereas when you compare with the remaining, the local controls in the more older IRS studies were much better than this. So there is an implication of local control when you're reducing the chemotherapy dose also. So when you're reducing chemotherapy dose, the radiation oncologist should not reduce the radiation dose also. So you have to strike the right balance there. So when you came back to 36 gray and you added cyclophosphamide, the local failures was 0. So there was a 15% difference in the COG study when you actually did that. So that was the question that, is it really safe to reduce the chemotherapy dose when you wanted to reduce it? So generally the dose that one would do now is 41.4 gray in 23 fractions for microscopic disease, 45 gray for R1, that is microscopic positive disease, and if you're doing 50 gray for the gross disease. For large tumors, there is a COG study that is currently going on where they are escalating dose to 59 gray for large non-resectable tumors. They feel that possibly 50 gray is not enough for these, and this is currently ongoing COG study. So we will have to avoid the results. I feel the results will be better in these. I told you about the fraction size of radiation. 5 gray per fraction will have more side effects, and that is the basis for hyperfractionated radiation therapy in children. This was a study from Stanford. The side effects were similar. They reduced the dose per fraction to 1.1, but the local controls were pretty same. One last aspect I wanted to bring up here. was the importance of radiating the retroperitoneal lymph nodes in paratesticular rhabdomyosarcomas after you have done surgery. So even if you have done surgery, you have done an RPLND and your nodes are positive, although you dissected all the nodes, still adding radiation therapy to the RP region improves overall survival. You know, you can see the difference in 5-year overall survival, 36% to 90%. And if you are treating with chemotherapy and you have a complete response, can you avoid radiation? You cannot. You need to do. So that was another thing that I wanted to bring up. Techniques, broadly, I can tell you that conformal techniques are essential for improving the outcomes, not outcomes, but outcomes in terms of toxicity in rhabdomyosarcoma. You can do protons, you can do IMRT, you can do brachytherapy. I'll not go into the details, we don't have the time. But broadly, one needs to understand that conformal radiation techniques in the form of IMRT or tomotherapy or proton beam therapy all reduces toxicity. It may not improve local control, but it reduces toxicity significantly. And I mean, these are just studies to show that the amount of normal tissue sparing, the green area, you can see 5% sparing of hypothalamus, 20% sparing of pituitary, 9% sparing of brain with proton beam therapy when you compare it with the X-ray. So that's the kind of benefit they can get. But these are all theoretical things. But yes, you know, yeah, Gauri is smiling. But we will prove it, Gauri, very soon when our proton starts next year. So yes, and of course, brachytherapy, I'm not going to show brachytherapy here. Brachytherapy, you surely, as you have seen in your own case, that is a fantastic outcome with brachytherapy. I don't think you could have achieved that with external RT. You have a 5-year local control, no side effects in this child, as I understand, despite you giving 5 gray per fraction, which I'm not very much for. So, but yes, brachy is great. So that's it. We can take questions.
Any questions? We can maybe unmute the participants if they have questions.
Yeah, I'll just stop share so that we know.
I think there was a question on ovarian transposition. I don't know whether it was answered already.
It was answered. I think there was
I have a question. So this reduction in dose from 45 to 41 gray for complete resection and microscopic disease, how much does it translate actually in reduction of late effects in your clinical practice? So reduction by 4 gray, does it really matter in terms of reduction of late term side effects?
Yeah, really speaking, I don't think so. I don't think it makes a huge difference, but maybe reduction to 36 would make a 10 gray reduction would make a difference. So, you know, why we push people to do surgery is because if you don't do surgery, you're doing 50 gray. If you've done surgery and because of some reason you're giving radiation, you're giving 41 gray. So you're giving a 10 gray difference. So 10 gray difference, yes. But more than the dose, I think it's the way you deliver it and what you contour. You know, I may be giving 41 gray, but I'm firing through and through, then you're gone. So I think small things, all these things add up. But you have a very valid point, 45 and 41, what are you really achieving? Yes, you are right. Yeah. We don't know, but lesser the better. You know?
And when you radiate these patients with genitourinary tumor, how do you make sure like the bladder volume before every fraction? Is it same? Is it different? Bladder is full, sometimes bladder is empty. So how do you actually manage that?
So when you are doing genitourinary, you are either talking about bladder or you are talking about prostate. Now, if it is prostate, the problem is there of movement, but the problem is not as much as you have to handle when you're doing bladder, because the bladder is moving all the time. Prostate is moving less. When I'm doing bladder, I always have a Foley's catheter in place. So we clamp it. So when we're doing a simulation, we ensure we instill a particular volume into the bladder with contrast, and you clamp the bladder and keep. and then you have done a radiation planning. So your radiation plan is made for a particular volume of bladder. So tomorrow when this child comes for radiation treatment, when you're imaging, you already know that you have this much in the bladder, and then you do. So you empty the bladder, put that much. So you are dilating the bladder that much every time. So that will not be 100%. And of course, we have the fancy image-guided radiotherapy techniques, which we brag about. So we do image guidance. So as the tumor is moving, as the bladder is moving, we guide our radiation. And that's why you end up paying so many crores for our machines.
That's true. Any other questions from audience or from any other participants?
I guess Sunil is going to throw us out now.
I'll just say quickly, there are
I think we're having interesting discussion. Yeah, don't worry.
2 or 3 people are asking about role of debulking surgery, and I want to again emphasize there is no role of debulking in pediatric solid tumors. Either you have an R0 or an R1 resection, because the dose of radiotherapy for residual disease, gross residual disease, is same. Whether you do debulking or not, the dose of radiation is same. So do not do debulking.
And the volume actually increases, Gauri, because you've contaminated the area. The areas that we need to treat is more. So it's worse,
Then people have asked RT before surgery or surgery before RT. Anybody wants to take that?
So if surgery possible, it should be surgery before RT, because you have a chance of avoiding. And your volume reduces, your dose reduces. If you do RT before surgery, the surgeons will not get a chance to operate.
Very true, sir.
I think Sajid is somewhere listening.
Shalini can't hit me from there. So
You saw the tumor disappear just with chemotherapy and then radiotherapy. We had no role. I was just doing scopies, that's all.
Yeah, I know. There's a majority chemotherapy. We better behave ourselves here.
I think one pulsed back question also came. So now the way we give actino and cyclo is single dose every 3 weeks. We do not give actino over 5 days or cyclo. So everybody, irrespective of risk, we give actino and cyclo as single dose every 3 weeks. Vincristine initially every week and then every 3 weeks along with actino and cyclo.
So did you change it in COVID times, Gauri?
So what did we do for COVID? I don't know. Sunil, you're allowing us COVID questions? Or time is up?
Yeah, of course. We can have a couple of questions. I think we still have 50, 60 people all listening to us. That's all right.
Going down. Better exit before it goes down to 0.
Yeah.
So in COVID times, what have we done? Initially, we were very scared to give chemo, but now we have realized, if you want curative intent treatment, you have to give curative doses. If there is an option, then we will take the less intense option. But curative intent is there, then I will give the curative dose.
Yeah.
That's the only thing. There's no point giving suboptimal dose, then we are nowhere. But patient has to understand supportive care, infection prevention protocols, they have to be very strictly adhered to. It's difficult. I mean, it's horrible when your neutropenic patients get COVID.
Yeah. We have some kids. So great.
Well, so we had a very interesting session. I think Sandeep, fantastic job in getting all the 3 stalwarts together. It's not an easy job. And I think we had a comprehensive discussion on all the 3 aspects. And I really appreciated the time you all have given for today's session. So thank you very much again, Dr. Lashkar, Dr. Shalini, and Dr. Gauri for a fantastic deliberation today. And I think a lot of basics got covered and a lot of doubts got cleared. So thank you, Sandeep, again. And thank you, Ayushi, I think was a fellow who presented the case. And we'll see you again next Thursday. And please don't forget to give your feedback for changes, modifications, and suggestions. Thank you very much. Have a good evening.
Thank you, Sunil. Thank you. Wonderful.
Thank you.
Thank you, Lashkar.